Well, thank you, Joan, and thank you, IRDEX, for putting on this little symposium. We're here, my name is Ahmed from University of Toronto, and with me I have Shoham. Shoham, who practices in Eastern Canada, was one of our recent fellows, and he actually had a lot of experience with our transscleral cyclophotocoagulation approach, and so I have asked him to join me here, and thank you very much, Nir, for being here.
Sure.
I feel like I'm a talk show host a little bit here. And I want to say hi to all the 150 countries out there that are being beamed this broadcast live, along with our large crowd that we have in front of us. Now, our presentation today is meant to be a bit thought-provoking. We want to basically re-examine and talk about our approach, somewhat anecdotal, somewhat research-based, on how we look and approach the use of transscleral cyclophotocoagulation. These are just some of our disclosures here for this meeting, and what we're going to cover is talk about transscleral cyclophotocoagulation, changing approaches, changing attitudes, changing techniques, and maybe changing indications here, and that's kind of what this is about here. There is a fair amount of data out there in the literature, and I encourage those to seek those out. I don't want this to be a large data dump where basically we're going over slide after slide of data. We're happy to highlight important data points, and we'll go for that as well. So, just again to sort of put some thoughts in the minds of our audience members here. We're calling this the new approach, or the new transscleral cyclophotocoagulation, and some of this is real time now, and some of this is perhaps theoretical. When we talk about indications, for example, we'll talk about indications, but where does it fit? Using after patients have failed a filter or a trab or a tube. Using it perhaps as a primary surgical therapy for certain patients or for all patients are a question mark. What about in eyes with good vision? And what are the modifications in the technique and the technology that maybe allow us to practice in a safer and a predictable fashion? So I'm going to read this quote from the American Academy Technology Assessment, and I'm going to ask maybe Nir for his comments shortly. But I'm going to read this basically, that cyclophotocoagulation is indicated for patients with refractory glaucomas who have failed trab or tube, patients with minimally useful vision and elevated pressure, patients who have no visual potential and need pain relief, and patients with complicated glaucoma and conch scarring from previous surgery. So that definitely certain pigeonholes the procedure. And I have to admit, when I started practice about 11 years ago, that's kind of how I looked at transscleral cyclophotocoagulation. We didn't do a lot. Nir, you've seen us using it over the last 3 years. What are your observations as far as this indication and what you think and what you see perhaps of the opportunities here?
Okay, so for sure, according to the American Academy, and I think what we've all been trained for in residency, is to do CPC when it's kind of a last resort. So it's a blind, painful eye, then you go for CPC. But what we've seen in the past, what I've seen in the past 3 years, and our experience with CPC is that even a good seeing eye, and we have done good seeing eyes with vision of 20/30, 20/40, 20/50, if you think by going into the eye and doing a filter, either a trabeculectomy or a tube shunt, you're risking IOP fluctuations too much and a potential snuffing out if the patient has not lost fixation already. Transscleral CPC seems to be a very safe approach. That's my opinion, and now starting out in practice, I do get patients that are pretty advanced that I am thinking of maybe even doing it as a first approach, because I'm really concerned if I have a patient with an advanced visual field involving the 10 degrees of central visual field with a 0.95 or even 0.99 cup, I am concerned of what do I do? Do I expose him in a way to a trab or a tube, or maybe go with something that's potentially less invasive?
Yeah, I mean this is really kind of coming full circle, which is perhaps a little bit surprising. I think there are going to be many who are going to be. Did I just hear that from? Well, maybe they're used to hearing from me, but I hear that from a very capable and well-respected new member of our community here, Nir Shoham. And we want to talk about that because I think there are rightfully questions about should this be a procedure that we actually use it in this case. Well, why would we not use it? Like, why are the concerns for CPC? And when we talk about CPC, let's remember that we're talking about in the context of all our therapies, whether they're medical, whether they're laser trabeculoplasty, MIGS procedures, and then scleral filtering procedures, trabs and tubes. That kind of breaks down the different categories, right, Nir? So, I mean, the main concerns, I think, when we think about both study-related and theoretical, I think hypotony is a big one. Gosh, we're going to basically be lasering the ciliary processes. We can't. If we get low enough, we can't reverse the process. Inflammation, we're lasering uveal tissue, related to CME. Loss of vision, I think, is one that we certainly are worried, especially as you mentioned some of the sighted eyes, and then the early postoperative pain. I think that if we're going to get to the level that you suggest, we have to basically allay these fears and we have to address these. Any early comments on that? I know we're going to talk about it a bit later, but any thoughts on these issues as far as concerns? And
so for sure, when we do surgery or any intervention, we of course involve the patient in the decision. So we tell them, these are the risks, these are the benefits of this procedure versus another procedure. And one major risk that we do say is hypotony. So we tell them, the eye might go soft, might change shape, but in my 3 years, I can remember maybe a patient or two that had some early hypotony, and pressure later on rose to, I think it was low teens. In terms of inflammation, we monitor them in the first month. So usually we do the laser and then see them a month later while they're still on anti-inflammatory drops. If there's any greater concern or if they do feel pain, and again, if I think back, maybe 1 or 2 patients came back with a sore eye, we do give them anti-inflammatories. I don't think it's a major concern, at least from my experience. And vision loss. So again, you have to weigh the risks and benefits of transscleral CPC versus doing an intraocular procedure, even with patients or on patients with good seeing eyes. And I'm fairly comfortable with doing it if I am extremely concerned of doing big surgery.
now there's a couple of points I wanted to add to Nir. I mentioned the same complications when I book a patient for tube shunt or trap. They may get hypotenuse, they may have choroidal hemorrhage, they may have other issues. We mentioned that. And so does Michael Berlin, I'm sure. Thank you. So these are the concerns that we always mention, and I think where we're going to get to this is that we're going to see some improvements in our procedures, our understanding of the procedure that I think are going to allay some of these fears. So the fail filter is one that immediately comes to mind as far as a patient who in my mind will perhaps be the first patient to look at as far as patients that we'd want to do something of this nature. Our options include, of course, doing a second trabeculectomy, doing a tube shunt, or doing a cyclophotocoagulation. Just briefly, Nir, do you want to talk about how you look at these three options and what would steer you one way or the other for a given patient? Again, failed trab, you probably needle them.
Exactly. So I would, if one trab failed, I don't see the reason of doing a second one. Probably there's a reason, maybe my hands or another surgeon, that this first trab has failed. I would not repeat a trab. So second option would be a tube. Sometimes it would be the first option. But again, if I am concerned of the post-op course, if I know potentially maybe that I would not be able to monitor this patient. So I know that patients used to come to us from kilometers away, and I am confident with my CPC, I might steer toward doing this intervention and now gaining some experience with it. I know that it's not only indicated for blind, painful eyes. So I'm not going to get hypotony, I'm not going to lose vision while doing the procedure. So potentially it is perhaps third in the indication, so it might not be my first line, but it's a pretty close third in high-risk eyes.
I mean, when we choose surgical procedures, we obviously weigh risk and benefit. This is the group of patients that, unfortunately, no matter what we do, there's going to be a higher risk of complications, and I think it's balancing out, those complication risk profile. I'm going to tell you what I think are probably one of the most important factors. You mentioned them already, and I'll mention that shortly. And it relates to this issue, which is basically visual acuity. I think that we've often looked at cutoffs for visual acuity, count fingers or whatever it may be, to say this patient would be a trab or tube, this patient's going to be a cyclophotocoagulation. Maybe it's 2100, maybe it's count fingers, maybe it's hand motions, but people generally have had cutoffs. And I had the same way. I mean, we maybe did 1 or 2 a month 10 years ago. Now we do maybe 15 to 20 in a month. So I mean, we've really shifted around. It's because our comfort level in dealing with patients who've had good vision has been good, and also the corollary to that, patients who we've done trabs and tubes on with good vision, we've had unfortunately, complications with that. So of course you balance out that nature. So this was one study that looked at basically 49 eyes, medically uncontrolled, who declined or were felt not to be a good candidate for surgery, which is kind of what we had talked about. Transscleral cyclophotocoagulation was performed. These patients had good vision. Pressure reductions you see less than 22, 90%. less than 17, 75%, 73%, reasonable number. 18% of patients with 20/60 or better experienced vision loss. Okay, so these patients were eyes that had good vision, but they experienced some degree of vision loss. 18%, I don't think it's a high number, but it is a significant number to think about. Keep in mind that when we look at other comparisons, for example, the AGES study, of course AGES advanced glaucoma, medically uncontrolled, randomized to laser trabeculoplasty versus trabeculectomy. You look at some of that data and you got 40% of eyes now that had 3 or more lines of vision loss. So they're not direct comparisons, but it just gives you a reflection that vision loss is an issue no matter what we do with these eyes, and the majority of these eyes lost vision because of glaucoma progression in these examples. From the same paper, the Rothford paper shows the different studies out there and showing the different percentage of vision loss. Keep in mind that some of these were very high risk eyes as well. Neovascular eyes, complex eyes. It's always important to look at this in perspective. And on the surface, if you see these numbers and see a high percentage of vision loss, you're going to turn and run away from the procedure. But when we look at the natural history of the disease, when we look at the alternatives, I think we have to put it in perspective. And that's why I think we've revisited it. Now, truthfully, of course, I look at the disease being an outflow disease, right? Let's treat the disease, let's treat outflow. And once we get an outflow procedure that's going to be low risk, that's going to lower enough, I will be honest with you, I'll say I'm not sure how much of a role transscleral cyclophotocoagulation has, truthfully told. But when we look at the balance of things, the reality is we don't have that. And as we move forward, as we'll hopefully share some ideas, using transscleral in maybe a modified mechanism of action maybe provide some options for this. So, these are some of the reasons why transscleral maybe is not something that's a first line option for patients who are virgin eyes with good vision that may be worried about it. So we talked about the risks of the alternatives. These need to be compared. We need to compare these eyes. Obviously when it's clear that a trab or tube is not desirable, transscleral cyclophotocoagulation is clear. But what about beyond that? We pulled some of this data out from the TVT study. Remember, this was basically a variety of eyes that had some sort of procedure performed, phaco or failed trab, that went on to have a trab or tube. And whether it's a trab or tube, over 5 years, almost half the patients lost 2 or more lines of vision. And again, glaucoma being a large chunk of that. So these eyes lose vision. Is it the disease? Is it the procedure? Is it both? Honestly, we need to take a good look at this, and we'd love to see a real well-designed randomized trial to compare, to answer these questions that we're asking here. The one thing that we do take heart in is that this is truly a non-invasive procedure. That's an attraction to that. We're really high up on the MIGS procedures, whatever canal-based, suprachoroidal-based, subconj-based, and these are great options, but they are invasive. There's an element of invasiveness. We have a great promise for MIGS. We're looking at this in a slightly different patient population. And this is the patient I worry about the most. And I get a lot of these. We see a lot of these near, right? The worry about the snuff out in glaucoma in these kind of patients here. And we look at some studies, up to 6 to 8, vision loss, severe vision loss in patients like this after filters, trabs or tubes. And that's alarming. I think the rate may be even higher. And I tell patients, 1 in 10. That's a high number to be looking at. Yep. What is the number in CPC? Well, we're going to have a fair number that are going to lose snuff. By snuff out, by the way, I mean acute vision loss after surgery is gone, not after 5 years. Obviously, if you go over time, you're going to have more vision loss. But these are the ones where it scared me enough with my experience. And again, we're very much surgical, right? Mm-hmm. We love surgery. It's not we don't shy away from surgery. We're shying away from surgery. That tells us something here. Nir, maybe let's talk about technique a little bit. You've kind of seen us kind of shift a little bit from the classic therapy, which maybe you can talk about. Mm-hmm. You can talk about the experience with that, to the Gasterland slow coagulation or slow burn technique. Maybe you can give some thoughts, as I know that people have been talking about this. We've I think, seen some benefit in this. What are your thoughts on that? Okay,
so traditionally what we've done, or what I started off during fellowship, was traditional values, doing about 2,000 milliwatts per 2,000 milliseconds. We put retrobulbar block each patient before CPC, and then we did about, 360, treated 360 for approximately 24 applications. Pretty high energy, when using these traditional values. And what, of course, sometimes you hear are pops, occasional pops, or more frequent, which you kind of have to titrate down. We've started using the gastrolin, or the slow burn, or I like to call them slow cook technique, whereby we use lower energy but higher duration. What, from our experience, what I've seen was patients are far more comfortable. You rarely get a pop. You sometimes hear pops in more darker pigmented patient, but that is rare. I remember 1 out of tens of patients. And an important thing is, I think patient comfort is a great issue. And I think with a slow burn, you get much greater comfort in terms of patient. In terms of the results of IOP lowering, I think it's still early for me to.
We're looking at that. Yeah, I mean, and I think we're going to see a very similar IOP lowering. The idea, again, classic technique as Nir described, you want to hear some pops. That's the teaching, right? You want to hear some pops. Well, a pop is pretty traumatic. That's the kind of thing that's going to increase the risk of inflammation in CME and other potential complications. And if we can actually deliver this potentially even with more total energy, actually, for the measure of the total energy being higher in joules, but yet over a longer period of time with lower energy, avoiding these pops, that's the benefit. And where this really struck me was when we do ECP. And we maybe will ask that question because we have ECP as well, but we use Transscleral on these eyes rather than going to do ECP on these eyes, and there's reasons for that. But when we do ECP, what are we doing? We're painting the process, we can visualize it. It's nice to see the process, the shrinkage of the process progressively until you reach an endpoint of whitening and shrinkage. And that's a slow burn, right?
Yep.
In essence.
That's true.
So, and that avoids the pop. Well, we're doing the same kind of thing, but externally here. And I think that really captures, to me at least visually, why this I think is advantageous than getting a bunch of pops where you are going to cause extravasation of inflammatory cytokines and everything else that occurs with it. So I think Doug Gaston, who's really been a pioneer in this area, I think is onto something here. And again, we are looking at embarking on studies comparing the IOP results. So I think that's something that I think is worth looking at. One thing we do though, we do know of course that we do have a certain number of retreatments. And maybe we can address that issue because I know that we often talk about retreating. You do a trab, I got to do a second trab. That's considered to be a bad thing,
exactly.
Right? If you have to do a second trab again, you're in the eye again, it's a bad thing. Do we apply the same logic to retreating with a transscleral CPC?
So what we do, first of all, when we see the patient back, we see that the result was not as anticipated. The good thing is you can repeat it. Again, it's an extraocular, so you're not going in and doing full-blown surgery. And again, you can titrate the amount of energy you want to deliver. If you think that initially you have applied, let's say, the traditional values and you've not reached the goal in terms of target pressure or maybe lowering, decreasing the amount of drops, you can just increase the energy by a bit. I think that's the beauty of it. It's an in-office procedure or clinic, outpatient clinic. It's not taking the patient to the hospital or to the operating room, and you still can titrate. You can use either higher energy, lower energy. If you're more comfortable, you can do only 180 degrees treatment at a time, but I think that's the beauty of just titrating. You can always add more.
In glaucoma, we talked about the holy grail being titratability. That is going to give us flexibility. I look at this as titratability. We do a little bit of that with laser trabeculoplasty, and I think this is very similar. This is a non-invasive approach, so it's not the same level. In fact, we purposefully will often do a gentle approach, maybe less spots around if we're worried about any concerns, and we can then titrate up. I think it's a great way to do it. And we do this in the, maybe we can address that issue as well, is the office-based procedure, because we've now started to do this in the office as well. And Nir, you probably have some of the most experience within our group of doing this. Nir's done a lot over the years he's been with us. I mean, how have you found that? We've done it in a hospital, we've done it in the office. I mean, what are your thoughts on using it in the office as well?
So the major concern or the major difference is, of course, the retrobulbar block. Where one of the devastating complications of a retrobulbar block is a retrobulbar hemorrhage. Another is, God forbid, if you go in too deep with the injection, potentially you can initiate a brainstem anesthesia, which if happens in clinic, in an office-based clinic, that's, I think, a major concern. If you're in a hospital setting, well, you have anesthesia there. You have an anesthetist there that potentially can come in with within reasonable amount of time. So I think that would be a major difference. What we've done in clinic is try and prevent going as far as a retrobulbar block, but do an more anterior approach, anterior to the septum, and do a peribulbar block. Sometimes it takes better, sometimes it takes not as well, and the patient needs some topping off. What we've done is I usually applied either one inferotemporal block, peribulbar, but if that would not be enough, I would add another one, for example, a supranasal peribulbar block, which usually should be enough.
Yeah, I think the transition to the office is that's the key. Is how you block the patient. And I mean, right now with our approaches, we need to block patients. It is an uncomfortable procedure. There are ways of working around that, but we need to block them, and I think that's the biggest factor. But I mean, office has been very helpful in that. Let's switch gears a little bit and talk about some of the new approaches with cyclophotocoagulation. Of course, the mechanism of action felt to be related to reduction of aqueous secretion. It's some very interesting work. This was out of Singapore, and others have been looking at this, and we're looking at this as well, which is micropulsing. And this is potentially a safer, better tolerated transscleral procedure, potentially earlier in treatment, and potentially an alternative mechanism of action. And this is sort of a modified G probe, a pars plana probe, that basically is placed over the pars plana, and using basically 2 watts painted over the pars plana region. You can see the duty cycles at 31%, 600 or so, 25 pulses per second. And so basically, very much like how we see in phaco, we micropulse and we can reduce the some of the complicated side effects of phaco energy and distribute equal, in a more efficacious way. The idea here is basically to do it in this manner. And so some of the early results as we see here, we've seen some of the publications, we're seeing some pressure reductions. And the nice thing here is that we see some of the risks and some of the complications seem to be lower. Vision loss, hypotony seem to be lower, and certainly in this study there was no cases of hypotony in this particular study. So micropulsing, I think, is an exciting area. We've seen it in retina. I think that it's coming, and it's already arrived in glaucoma. We need to study it a lot more. There's so many different things that we're excited to look at. Whether we're stimulating some sort of uveous scleral mechanism, whether we're still creating some reduction in secretion is debatable. But I think that could really switch gears as far as treatment. And of course, we think, and we'll need to see whether the discomfort may be less. So I think micropulsing has some interest. We're just coming toward the end of this discussion here, but I wanted to sort of just touch on these points here as it being a non-invasive procedure. And maybe as we talk about that, maybe Nir, you can just address this issue, because we do have ECP as well, and we do like ECP, particularly in combined phaco with angle closure eyes. We won't get into that too much, but what about the argument of using ECP endoscopically delivered versus doing a transscleral for these eyes as solar procedures, for example?
So when we do endoscopic cyclophotocoagulation, usually we treat about 180 or maybe extended to 270 degrees of treatment, but still we're kind of doing we're not destroying the ciliary body or ciliary processes entirely. We are seeing some decrease in aqueous production. There is both a mechanical effect as well in terms of opening the angle when the ciliary body ciliary processes shrink back. However, in terms of a large drop in IOP or drop reduction, I think we do see around probably 30 or 40% in IOP reduction, and still it is a minimally endoscopic cyclophotocoagulation still is a minimally invasive procedure, but still is intraocular. So in someone that I am concerned of opening the eye and causing some fluctuation intra-op, I will lean toward transscleral, which I think it has the potential of being more effective.
Yeah, there's a different element of doing this non-invasive versus invasive. I think that's the key there. And I think with ECP, you really got to crank things up, and you really got to do a lot, because you just can't apply the laser to the entire ciliary epithelium. There's only a certain part you're exposed to. I mean, ECP has a role, no question, but I think there's a certain attraction doing this in the office, non-invasive. There's a big attraction to that, and that's why I like using it in that kind of a category. Now, that being said, we need to manage these patients carefully post-operatively, especially the ones that have good vision and we're worried about things. We need to follow them closely. We need to treat them with anti-inflammatories. I think the role of NSAIDs has been shown to reduce some of the pain during the procedure when given pre and immediately before. And we need to look at using NSAIDs pre, post, topically, oral, maybe even in order to look at that. And also topical steroids are very important to use in the early post-operative period. We do also suggest continuing to use the glaucoma medications, and we'll often add systemic CAI if we're really worried about pressure spikes, just as we would for other potential surgical procedures, for example, even in a Bearville tube, for example. So I think that's sort of our approach post-operatively. Titratability we did discuss. I think that it actually gives us an ability to titrate. I mean, we're not looking at doing, for example, patients that have advanced glaucoma, and we don't want to do a trabert tube for what we mentioned. They have a cataract. We may do some transscleral, CPC, get them down into the high teens, and then do a mixed procedure on top of that. Okay, after that, and get them down to a good target. I mean, talk about titrating and using all the options we have in glaucoma. So this is really, I mean, I don't want to overemphasize it, but this has really been an eye-opener for me over the last probably 3 or 4 years about how, we've been able to incorporate Transscleral in our practice. I mean, really it's made a difference. And I'm happy to say we haven't seen with our approaches, any increased complication that we would see with the filters and the tubes. And like we said, we think it's less. We need to do studies on this as well. And micropulse, of course, will be of interest. So we do want to have some time for questions if there are any. But I hope we've shared with you in a conversational way how we have approached using Transscleral. We have at our disposal almost all the glaucoma surgical devices and products that we have that are out there, luckily enough. And we find a role for Transscleral, and it's an important role for that.
I think there's also we should kind of change the way we think from a cyclodestructive procedure to a cyclophotocoagulation. When I think of it coming out of the fellowship, it's not anymore a cyclodestructive procedure. So when you think about it as cyclodestructive, yeah, it sounds like you'd only indicate it in a blind painful eye. But it is, in a way, minimally invasive. You're not entering the eye, so it is a cyclophotocoagulation. Cyclodestructive, I don't like the name.
Yeah, I don't like the name.
I don't like this to destroy. I think all we're doing is trying to build.
Right. We don't call it. We're going to do some retinal destruction for your diabetes.
Yeah.
That's a good point. That's a good point. So we're seeing increased utilization in sighted eyes, in specific indications that we mentioned. In those cases, that's often primary surgical procedures. And we do need to get some more data. And I think we're excited to be embarking on some of this work to do some proper trials. We're very excited about micropulsing. There's a lot of theory that has gone into this to understand the right parameters for micropulsing. I think that's going to be very exciting. But this has been a rebirth. I mean, really, it's really been a change of how we've been looking at it in a very positive way, and that's why we want to share that with you. So, well, thank you, Iridex, and thank you, Joan, for asking us. I want to thank Neert for doing a great job working with us. I mean, it's been great looking at this in a group together. And I think I would really encourage you to, those of you who have, transscleral cyclodiode, I think it's worth looking at this. And I'd love to see people collaborate and do more studies on this, because it just gives us, I think, another option, a strong option for eyes that maybe not classic in the classic category. I think we have to get this, the covers off this idea, because in the end of the day, I think we're helping patients by exposing less risk to these patients.
And I think, just a note, like we had tube shunt surgery, which was initially indicated for only refractory glaucomas. I think now we're doing primary tubes, so potentially transscleral CPC may become, and I think is becoming more prevalent, and not just being left as indicated for blind painful eyes.
Well said. Well, thank you very much for attending.